I hope you'll have a wonderful stay out here. This presentation of mine, I would be doing it on behalf of the entire ACT team. Everyone knows the burden of the preterm births worldwide. Millions of babies are born less than 37 weeks. So prevention of preterm births is yet a dream due to huge knowledge gap with respect to the drivers of preterm deliveries and preventive interventions. It's a well-known fact that administration of antenatal corticosteroids to the pregnant woman at risk of preterm delivery is most effective intervention to reduce neonatal mortality in preterm births, especially in the hospital settings. We do have sufficient evidence from the vast trials, that is 21 randomized trials, more than 4,000 mothers and babies involved, comparing the effect of dexamethasone or betamethasone versus the placebo or no intervention, summarized in 4 systematic reviews. These are the effects of the antenatal corticosteroids, the beneficial ones, that can be seen here. In spite of that, the use of antenatal corticosteroids in preterm births in the low middle-income countries is just 5 to 10%, as compared to 80% in the high-income countries. Well then, why is an intervention proven to be effective, safe, easy to administer, and inexpensive in most high and a few middle-income countries, still underused in low and middle-income countries? There could be several factors at play, like organizational factors, the factors related to health providers and the policymakers. Also, factors related to women too. With this research question in mind, this ACT trial was conducted in 6 countries, 102 clusters, involving more than 99,000 mothers and more than 1 lakh babies over a period of 18 months intervention. So, with the trial questions as to was this particular intervention, is it feasible under routine conditions to scale up the use of antenatal corticosteroids in the low middle countries? Also the question, were antenatal corticosteroids effective to reduce the neonatal mortality in low resource settings in the absence of newborn intensive care? Were antenatal corticosteroids safe for the mother and or newborns if scaled up at all levels of care? These were the trial questions. With an objective of a multifaceted intervention, whether this would increase the use of antenatal corticosteroids from 10% to 50% for live births. The other objective is whether is it possible to reduce the 28-day neonatal mortality of small babies by 30%? And also, was it safe in the mothers and their infants? Antenatal corticosteroids used in low-income countries, well, a big question mark that was there. Not sure whether similar neonatal mortality reductions would occur in settings without neonatal intensive care facilities, settings in which preterm birth risks were maybe less accurately assessed, risk of antenatal corticosteroids-related infections leading to increased morbidity for women and their infants. So a multifaceted intervention was developed to improve the identification of pregnancies at high risk for preterm birth and also to provide and facilitate the use of antenatal corticosteroids. It involved in-depth training, and the train-the-trainer model was used, wherein the development of training methods with the central team was done. Training occurred at each site. Each site further trained the field staff and local providers of health. Of course, with the engagement of the community. And basically, the training involved the how to identify the woman at risk of preterm birth and referral recommendations. So these were the predictors of high risk, predictors of preterm birth that were involved, like, did the woman between 24 to 36 weeks, is she having any pain in the abdomen? Is she having any leaking? Is she having any sudden severe headache? And that's the reason she is taken to the hospital and her blood pressure being checked. Did she have any PV bleed? So basically, these were the predictors that were used, and the women, the ASHAs, were educated using these particular posters and putting these particular pictures that have been highlighted on this particular slide. These were the materials that were used for the ACT trial. Basically, one of the important things is the preterm ACT kits that were done, which included the dexamethasone, 4 doses, so 6 milligrams IM at 12-hour intervals. There were syringes in that, there were gloves, and instructions on the box. We also did use the OBDIS and the fundal height tape for the gestational assessment, as majority of the times the LMP was not known and a proper dating ultrasound was not available. This is another thing that was used, that is the posters at the health centers, wherever the patients do sit and they could get an information regarding these antenatal corticosteroids. This was a referral process that was used. The pregnant woman with risk factor used to call up the ASHA, the accredited social health assistants, and in turn, they would call the ANMs, and the first dose of antenatal corticosteroids was administered, and then they are referred to the referral facility or to the primary health centers. Sometimes the women directly did go to the referral facility and the primary health center, and they did also inform the ASHAs regarding the same. And we delivered the kits to these particular places. Essential newborn care training for both the interventional and control clusters was done, and so many health personnel were involved in the training. The activities included community awareness meetings, identification of women by ASHAs at high risk for preterm birth. The first dose of corticosteroids was administered within the community setting by the ANMs, and then the referral was being done. And also training facility staff for care of the preterm babies. This study was conducted in 6 countries across the globe, involving 102 clusters, 51 in the interventional and 51 in the control cluster. But finally, in the control cluster, it was only 50 clusters, as one of the clusters withdrew them. So the final analysis was done on 51 clusters in the interventional one and 50 clusters in the control. The primary analysis population included the less than 5th percentile live births. This less than 5th percentile live births was the proxy that was taken for the preterm births, because of the reasons that I would be showing you in the next slide. So there were 2,361 women and 2,520 infants in the interventional group, as compared to 2,094 women in the 2,094 and women and 2,258 infants in the control group. This is just the study profile area of the Belgaum cluster. We had around 20 clusters and distributed 16 in the Belgaum district and 4 in the Bagalkot district.
Sorry to interrupt you, sir. Time is up.
The primary outcome measures were the 28-day neonatal mortality in births less than 5th percentile. I did tell you that this was the proxy for the preterm births, and the reasons are that there was no proper estimation of the gestational age, and the secondary outcome was the maternal infection. The use of antenatal corticosteroids in the less than 5th percentile birth weight was 45% in the interventional group and only 10% in the control group. Amongst all women, it was 12%. The strategy of intervention did not make any positive effect on the neonatal mortality. And in fact, the overall neonatal mortality and stillbirths did increase in both the groups. And also, furthermore, the maternal mortality too seemed to increase in the overall group. So this absence of positive effect on the neonatal mortality could have been, the reasons could be that there was partial coverage of antenatal corticosteroids, 50% late preterm births, absence of neonatal intensive care, newborns suffering from other comorbidities like infection could be in the causes, raising questions as to was there any over-treatment with the antenatal corticosteroids? Did it increase the susceptibility to infection? Was there worse quality of care in these intervention group? So in conclusion, the strategy of intervention not only was ineffective in the less than 5th percentile births, but it increased the neonatal mortality in the overall population too. Further, it also increased the maternal mortality in the overall population. With this, I conclude my talk. Thank you.
'08 for aspirin study. Dr. Hoffman has had master's degree in public health with a subspecialization in maternal child health research from Johns Hopkins University School of Hygiene and Public Health in Baltimore. Dr. Hoffman is a fellow in the American Congress of Obstetricians and Gynecologists. His other focus of study is medical education. He's also